Today's session is going to be focused on contract management best practices. My name is Brad Josephson. I'm with PMMC, and PMMC is a leading provider of revenue cycle management solutions. We are not going to be talking specifically about our software today, but rather about best practices related to contract management, some key issues that everyone faces, regardless of what system you might be using, and hopefully some best practices and tips to address those issues head-on, with meeting the ultimate goal of maximizing reimbursement. Today's guest speaker is Kristen Wood. Kristen has been with PMMC as a senior account manager for 4 years now, and Kristen works daily with our clients related to contract management. So with that, I'm going to turn it over to Kristen.
Good afternoon, everybody. Welcome. Thank you for joining us today. Just wanted to give you a little update on who I am. I'm originally from Northeast Ohio and moved south a few years ago, mostly for the weather. You can understand that. Like Brad said, I've been with PMMC for a while. Love working here, and I'm very happy to be providing this presentation today. I'm going to start off with talking about what a contract management is, what a contract management system is. I'm starting with this topic because it's most often the tool that offers more information about your facility's reimbursement, even more than your own billing software. Your billing software can provide you with raw information, charges posted, payments, and some analysis around those. But a contract management system is a tool that's designed to analyze and aggregate all of the information that comes into your billing software and goes out of your billing software. You should have the ability to model all of your healthcare payer agreements and calculate the rates and terms of those contracts. You should have good access to reporting tools that help you analyze your data and model potential contract changes. We'll talk about that in a little bit. It's crucial that your different departments at your facility work together to achieve your goals. This means meeting regularly with the CFO, the billing managers, coding department, and registration, and all of the other areas that affect your bottom line. Contract management can be the software that brings all of those areas together. So what are some of the problems that can cause an accounts receivable that is less than desirable? I cannot stress to you enough the importance of using the tools that you have available, or hopefully have available, to identify these problems. We're going to talk about each of these in a little bit of detail as we go through the presentation. It's very important that you have reliable, experienced staff dedicated to managing and negotiating your contracts. After all, that's where all of this starts, doesn't it? This starts with knowing who your top 20 payers are and making sure that you completely understand all of the complex reimbursement methodologies each of those individual payers use. For example, do you know the effective dates and the term dates of all your contracts? Do you have the ability to see if those are not paying correctly? If your contracts are from the 1990s and you know the insurance companies aren't paying those old rates, you have a problem. Do you have a way of catching when a payer changes what they're doing quickly so they can be addressed? It's important that underpayments as well as overpayments are reviewed as soon as they are received and posted into your system. Yeah, it's fine to go 6 months down the road or even a year or two to do a retrospective analysis, but I promise you, if you catch things at the time that they're occurring and address them with the payers, then you can prevent future problems down the road. The registration desk has a notoriously high turnover rate, so it is important that your facility have a comprehensive onboarding process and training program. Inconsistent training or lack of supervision will result in sloppy insurance plan registration and low collections of patient balances. Accurate patient registration starts with verifying the insurance plan eligibility. Let's get back to basics. As you know, incorrect insurance plan entry can cause claim rejections, but these are so easy to prevent if you've got really good processes in place. We recommend that each facility use an electronic process to verify insurance coverage at the time of admission. Self-pay patients should be identified early and routed through your charity care process if you have one. If you don't, get one. Price transparency is important to collections as well. Some of the most common registration pitfalls are, number one, the primary is entered correctly, but there's no secondary. You end up billing the patient, they end up complaining, you end up having to get that secondary information, another month goes by, you finally get payment, hopefully. It takes a lot of time. If your registration staff had correctly entered all of the insurance at the time of admission, all of that could be avoided. Another thing I see a lot are generic placeholder payer plans or payer mnemonics. If they're in a hurry, they might say commercial or Medicare HMO if your billing software allows them to put that in. Well, there's no such insurance company as Medicare HMO. So somebody has to go back and fix that. Hopefully you're scanning the cards into your billing software so they can look that up. Then they have to correct the registration, then send a claim out. All of this takes time. Time is money. We recommend that you take the time to review your payer master at least quarterly at the very beginning and make sure there's a good process in place for adding new ones. You don't want anybody to just willy-nilly add insurance companies. Again, you've got to control that at the get-go. It's very important that your registration staff have all the tools they need, not only to enter insurance correctly, but they also have the ability to collect money from your patients the way that you're supposed to. Common sense, I know, but I'm going to say it anyway. Incorrect or inconsistent billing and coding practices can result in lowered payments or even complete full claim denials. It's really important that you have a billing policy manual that is kept up to date. That is crucial. It should include information on correctly coding claims, as well as all of your compliance documents related to your government regs. This policy manual should address pre-authorization and pre-cert requirements for each payer and be updated if that changes. Adequately trained and certified staff are important here so that claims can be sent out correctly the first time. An ounce of prevention, you know the saying. It is important to also address your current processes for posting payments. Do you have rotating staff that manually post payments off of paper EOBs? I hope not. But if you do, please change so that you can have that process electronically automated. Computers make far less mistakes in this respect than people do. Finally, do you have a reliable process for balancing your transactions? Do you know the money that was deposited, and is that compared regularly to the money that you have posted in your system? It's really important that if you don't have any of these processes in place, you work with your vendors to put them in place. It can take time, but trust me, it's worth it in the long run. Your vendor for your contract management software should be able to help you with this and help identify areas of improvement. For example, you should be able to have a report really easily that shows unbilled claims or claims that are denied due to missing authorizations or anything like that, anything that can point you to specific process weak points in your billing processes. Prevention, again, is the best cure for claim denials. whether they're denied at your clearinghouse or later on at the payer when you get your remit. Again, your contract management vendor should be able to provide a lot of reporting tools that can help you figure this out and figure out where your efforts of improvement should go. You should be able to see who your biggest payers are by volume and charge amount, as well as the most common reason entire claims or line items are denied for payment. It is recommended that denial monitoring be an active part of your process. You may assign a task team, for example, for a quarter to analyze all of your denials, see where things are, and then use the information from that review to assign resources on special projects. When I do consulting, one of the ways that a lot of facilities find best to divide up their denials is by reason of the denial. What's the category? This can be easily divided into clinical, administrative, and contractual. A clinical denial is basically your medical necessity. Make sure you have a place where you can work those and obtain your medical records as needed. You should have a process in place for tracking individual provider trends. For example, if you have one ER doc who has a habit that is different from the norm, as well as payer habits. If you have one payer that all of a sudden is denying everything for medical necessity, that needs to be handled immediately. Administrative denials are all of your coding and billing errors. This can also be registration related. If a claim is denied, patient not found, or patient doesn't have this insurance. Very common. Registration can select Humana Commercial instead of Humana Gold Medicare, for example. I see that a lot. That caused a lot of time with somebody having to wait for the denial, get it corrected, and turned around and billed correctly. The biggest problem for denials are the contractual ones. These are the vague, kind of generic, denied because it's not following your contract. But it doesn't say anything else. You have no other information to go on. A lot of facilities just kind of ignore these or sweep them under the rug, or worse, assume that the provider, that the payer was correct. Don't believe it. Call the payer. Find out what they're doing, especially if you see a trend with a specific type of service. Call the payer. Get them to say out loud why they're specifically denying the claim. Then check your contract. Argue those successfully, and you should get a good return on the time spent working those. Your commercial payers, for many, many years, have resorted to some really sneaky ways of either reducing payments or denying claims completely. We all know who our biggest problem commercial payers are, but do you know exactly what your other payers are doing? You don't want to get hyper-focused on one particular insurance company and then ignore the others. Make sure you have the resources to look at all of them. Recently, we've heard a lot of new instances of a few commercial payers moving patients to a different payer contract that pays at a lower rate. It's like a silent PPO. It's very sneaky. This is only caught if your collections team regularly monitors the payer reimbursements. If you don't, you won't know that they're moving people and reducing their reimbursement. If you're working underpayments, or your team is working your underpayments, and they're happy with any payment, you're probably leaving a lot of money on the table. Another common reason for underpaid claims or line item denials are missing authorizations. These are really easy to prevent. And if you're not working those, you're just letting them win. Incorrectly bundling specific codes has also been a common tactic by commercial payers. And it's going to be hard to see sometimes, depending on the CAS codes or denial codes that the payers are putting on the remits. You may not really understand that they're bundling. It's fine if they say this service is combined with something else. But what is that something else? You're going to need to contact your payer and get the specifics. See what the policy is. Make sure that you haven't missed something. Any changes should be communicated to your contract management vendor so they can update the contract rates and terms in your software so that your expected reimbursement calculations are up to date and accurate. We also see many payers reducing the approved length of stay days so that the payment to the facility is reduced. You might have 17 days, but they only pay 12. And it's a big payment, so your collector might think that's okay. Well, hold on a minute. What does the contract state? Do you have a threshold? Is there a trim point? Is there other contract provisions that may allow for that reimbursement or disallow it? It's really important to pay attention to those. Anytime that your contract management software shows an underpayment that large, you want somebody to call and find out what the payer is doing. It's also good to see if this is a payer habit or a trend. If it's one account, great, you've got it solved. They'll reprocess the claim and pay it. But if it's a trend, you may have a bigger problem, and you may need to get other people involved to help get those paid. Some insurance plans have been making very subtle changes to your payer agreements. So when you get a new addendum, make sure you read it very carefully all the way through and compare it to your previous addendum. We're seeing a lot of very subtle wording changes that are coming in. Something that previously had been paid isn't anymore. Or suddenly multiple procedure discounting wording is included that wasn't there before. So you need to be able to catch these. On the other hand, if they start reducing payments and you look at the new amendment and there's nothing in it about multiple procedure discounting, don't let the insurance company take your money and put those terms in if it does not follow your contract. Pay attention. This is the golden rule here. Do you know what your government payer mix is? Do you know what percentage of your patients are enrolled in a Medicare or a Medicaid HMO plan? Do not be afraid to work underpayments and denials for your government payers. Don't be afraid to recoup recovery dollars just because it's Medicare or Medicare HMO. Many Medicare and Medicaid HMOs routinely underpay services. They also may not be paying at the correct percentage that you are contracted for. We see this a lot. If you have a new contract term and let's say they were supposed to pay at 100% of Medicare and now they're supposed to pay at 102%, have they actually started doing that on the effective date? All the time we see where 2 months, 3 months, 6 months goes by and they're not paying at the new 2% rate. You should be able to catch that, make them correct their system so that claims are paid correctly and that you're reimbursed the way you're supposed to be. You are entitled to be reimbursed correctly whether it is a commercial or a government payer. There have been many changes in our industry, especially related to state Medicaid. Recently there's been a lot of changes to inpatient and outpatient methodology. Make sure your collectors understand that very well. Do you have a reliable way to identify those underpayments and to work those denials? It goes without saying, ICD-10 is here. Your vendors should be ready and compliant with ICD-10, and you should be testing right now. Do you know what the impact is going to be, however? I don't want to scare you, but CMS has communicated that it expects a really big increase in claim rejections at the time of ICD-10 on October 1st. You want to try to minimize your risk and prevent as many problems as possible. This starts with adequate testing. Please be prepared and work with your vendors now to prevent any issues October 1st. Your contract management software should have the ability to identify anything going on at the time of implementation as well. If you start getting certain codes denied or something like that, you want to make sure that you catch it early so that things can be corrected in a timely fashion. You don't want to be one of those facilities that has a big problem because of ICD-10 rejection. Does that make sense?
Yeah, Kristen, I'm going to jump in here real quick. This has
Sure.
gotten pushed back so many times now. Is October 1st the real date? Is this really going to happen?
I think so, yeah. With some of the recent government legislation, yes. And the other reason is that we've got ICD-11 coming too. We can't keep postponing this. I'm reasonably sure that ICD-10 is still going to happen October 1st, finally. I mean, we started hearing about it in the 2000s, but frankly, a lot of us didn't think it would ever come to fruition, but I really think it's going to happen this year, I do. Many billing office directors and CFOs worry over the number of days your accounts receivable has aged, but they have no idea how to reduce your accounts receivable days. All of the issues that we're discussing today can help rectify this and make your accounts receivable manageable. It's important that you look at all of the areas that affect your billing and reimbursement. We're very siloed, so it's important that communication between the different departments happens so that everybody can help each other out and share information. Do you know who your big problem payers are? Do you know if you have accurate reimbursement calculations in your software? A workflow assessment is a service that many vendors offer. Oftentimes, if you're starting a new software implementation, they might throw in a workflow assessment. If not, this is something you may want to consider. Having an outside consultant come in and spend some time at your facility in each of the different areas, observing your processes, reviewing your policy manuals, etc., can be invaluable. Sometimes having an outside person come in and help you identify the issues and then also help you communicate them system-wide can be all that it needs to get the ball rolling for necessary changes. We started off at the beginning talking about what a contract management software is. Basically, we know that it models rates and terms for all of your commercial and government payers. Many software tools also include the ability to model or simulate proposed changes. This is really helpful. It's important that when you're presented with new potential contract rates and terms, that you have the ability to understand the impact this new agreement will have on your finances. That's the only way you're going to know if this is going to be good for you or not good for you. Each hospital's patient population is different, so you should be able to have a flexible tool that can fit your specific facility's needs. One example of how this can be a powerful tool is a facility I know of used a simulation tool on a new proposal. They thought it was great. They weren't sure. It was a really great proposal for one of their huge commercial payers. It was really raising the reimbursement for all their orthopedic services, like knee replacement. It was like tripling the reimbursement. Oh, it looked great. But it was also lowering their emergency room visit rates by a small percentage. Might have snuck by. They modeled and simulated those contract terms against a good population of those patients and realized their ER utilization was so high that they would have ended up losing a lot of money. They ended up rejecting that proposal and renegotiating one that did not include that ER drop. They had to give a little bit on the knee replacements, but that's fine. In the end, they still had a net revenue increase because of that proposal. Big deal. That's a very simple example of how contract modeling at the time of negotiations can be a big benefit to your bottom line. Another example is one that's more complex. This is a facility of ours called Adena Health Systems that had a wonderful outcome with the simulation. Brad, can you speak to this a little bit? Explain this to everybody.
This is a good story, Kristen. A few years ago, they were going through some staff turnover and going through some process changes. And in addition to that, they were working with, it was 32 different commercial payers. So they just had a lot of data to sort through. And at the time, they were using some tools like Access and Excel, but it was really just a situation where they had too much data to deal with, and projecting outcomes with that amount of commercial payer contracts was just really unrealistic. So what they decided to do is strategically focus on their top 5 commercial payers, and they simulated the proposed future terms with those top 5 payers, and they actually found from one simulation alone that they would have lost almost $4 million in reimbursements.
Wow.
So it really had a great, not only financial impact on the system, but it kind of gave them the confidence and morale boost they needed, especially with a new staff coming in and taking over. So they've seen some good results with it.
That's great. Very nice. Thank you. And you're going to be sending out a copy of this to the attendees?
Yes, I would. Yeah, this is a case study that will go out to all the attendees along with a copy of the slides.
Perfect. Thank you. The other thing that you can use modeling tools for is just finding out what a new industry change is going to do to your bottom line. You might not be able to change it, but information is useful to know ahead of time what the impact is going to be. For example, using if one of your Medicaids is changing to APR DRGs, which is a big trend we're seeing, or you've got a contract that's changing to EAPGs. Is that going to change anything like that? Are you going to, is your expected reimbursement going to change? It's good to know ahead of time. If you're going to have a really big change and it's going to reduce your net revenue with a government payer, there's sometimes nothing you can do about it, but if you know ahead of time, you can budget accordingly. So let's get down to brass tacks. What should I be doing on a monthly basis or a quarterly basis to find out all of the answers to the questions that we have? Where do I start? How do I know what the low-hanging fruit is? How do I know where my problem areas are or where I'm doing well? Well, there's a lot of different reports that you can get from your billing software, your contract management software, whatever. But here are some basics. These are the ones that I recommend you start off. Obviously, there's more, but these are the big ones that you really want to pay attention to. You may want to start running them weekly, or you can go straight to monthly. I recommend that you track your collection and recovery team's productivity very closely. This should be divided amongst staff so you can see who your problem performers are and who your stars are. I don't know if you divide your collection work between, depending on the size, between types of denials or types of underpayments, but your reporting should be able to account for that. Make sure you have a reliable method of tracking all of the accounts that they are working, and that includes successful and unsuccessful recovery appeals. If you see a spike or a high number of closed or unsuccessful recovery attempts for one of your collectors, maybe this is a training opportunity for that person. possibly. Sometimes with different types of denials, an issue can exist that makes it difficult for collectors to obtain medical records from your HIM department. That's another area where communication is really important. But you want to be able to track denials and underpayments and then be able to see why things are taking longer than you would expect. I recommend you have a method for each of your collectors for communicating issues as well as successes and tips for each other and share information. You want to be able to see on a monthly basis how much money they're collecting, how much money they are closing because they can't collect it, and you want to look at underpayment as well as full claim denials. You're going to handle them a little differently. You want to be able to see a full claim inventory of what was billed out. You want to be able to compare charges that are posted in your billing software to the claims that you're sending out. Are there unbilled claims? Are there payers that are taking a long time to pay? It's important that you know what each of your contracts are for how long they're supposed to take to process a clean claim. You should be able to have all sorts of different tools at your fingertips where you can identify the payers that are taking longer than they're supposed to process claims. Overpayments are also something that I would recommend you take a look at. You do not want to be caught by surprise by a sudden payer takeback. If they are paying incorrectly and you are seeing a lot of accounts with overpayments, you want to make sure that gets handled and the system corrected so that you don't have a huge refund that is owed to the payer. It's really important to identify the gaps in your processes that creates all of these problems so it can be corrected quickly. It's one thing for your collectors to be able to tell you all of the different statistics about what they're seeing, but someone needs to be able to take those issues back to the root cause. Is this a provider that isn't posting things correctly? Is this a provider that's not getting pre-certifications okayed ahead of time? Is this a registration error that's causing these problems? All of these are very easily preventable as long as you, number one, identify them and then put a plan in place for getting them corrected. What are the most common reasons for your rejections and your denials? How are you handling those? Denial trend reporting is huge. You want to be able to see if United Healthcare was doing really well, then suddenly their denials spiked. What caused that increase? You want to be able to identify that quickly. On a quarterly basis, you're going to want to do bigger types of more complicated reporting. For example, you should be able to get any of these reports in your billing or contract management software. They can be run anytime, but because you're dealing with larger numbers of accounts, you might want to wait and do these quarterly. A diagnosis analysis and diagnosis utilization of some kind is very useful. It's good to know what your most commonly used diagnosis codes and how they're being used. Do you see bad habits as far as your coding department? What's your bell curve look like as far as your diagnosis codes? You may want to have a certified coder at your facility. Also, periodically do a medical record review. Match what was documented against what was billed. Check your coding. That's a good idea to do regularly. If not quarterly, do that yearly. Take a good sampling of your charts for each of your modalities and major providers. It's important to stay on top of what your payers are doing overall. So if you have access to a payer scorecard or other performance reports, you should be able to see the average number of days it takes for a payer to pay in addition to all of the volume analytics. Like I said previously, each payer contract has a provision somewhere that tells you how long they agree to pay that clean claim. If they're supposed to process it in under 30 days, but their average time to pay is 60 or 90, you've got a legitimate gripe with that payer. Very often, there will be extra reimbursement or interest added to those claims. You don't want to miss out on that. Denial trending is crucial to your bottom line, so make sure your team has the ability to analyze and follow denials by denial code, specific code, as well as individual payers. Accuracy and variance assessment reports can also tell you how accurate your payers are paying your claims. This is a good way to figure out areas for a special team to work on a payer. For example, if Blue Cross is your biggest payer and they have a 1% variance rate, you might think, well, it's probably not worth putting a team to work just the Blue Cross. But if your volume is high enough, it might be worth it. You might be tempted to go to Aetna that might have a 30% variance rate, but if your volume is really low, it's not worth your time. So use those reports also to help focus your resources in the areas where they will get the most bang for the buck. Things that you can do now. Don't panic, first of all. All of this that I've gone through today are things that you probably already know. I think the main thing is communication with the different areas in your facility. It's really important that your registration, your billing office, your coding, HIM, as well as your collections team managers meet regularly to discuss problems and problem solve and find tactics to solve these issues. Many facilities find that these different departments never talk. It's crucial that they be brought together so that they can work together to solve your problems. If you have resource issues, if you think, wow, I don't have enough people to do all of this, you need to work with your budget office and your CFO to discuss your resource issues. Collectors generate revenue, so that's a good point to take to your higher-ups. If, however, it's not an option for your facility, it's a good idea to discuss areas that might make sense to outsource, even temporarily, to improve revenue reimbursement. For example, business office functions, claim rebills, even collection and recovery work can be outsourced by a vendor. Maybe while you get your team together. If you don't have a collections team or you only have one collector and you think you should have 5, well, it can take a year to get those people interviewed and ramped up. Meanwhile, you've missed all your filing deadlines, and there's a lot of revenue that you've lost. Don't be penny wise and pound foolish. Find a way. It doesn't matter who collects the money as long as the money is collected. That's my opinion. What would I do first? Meet with your collections team. They will tell you what their biggest problems are. Do you have resources that you need? Meet with the rest of your management team and talk about what the most urgent issues are. What are the hurdles that they encounter that are preventing them from being more successful? Do you know what your biggest payers are? Do you? I know you know what it was a year ago. Is it still the same? We've had a lot of changes, especially with all of the healthcare exchange payers that are coming into the marketplace. Things are shifting. What was your top 20 payers a year or 2 years ago may be very different. Make sure you also know what your biggest common reason for denials. This is where I would start. What's going on? Another thing to consider is when was the last time your facility had a charge master review? Some facilities look at those quarterly, some every 3 or 4 years. You need to know when the last time your charges were looked at, when the last time your fees were raised, etc. You've got probably provisions in your across-the-board contracts that are affected by charge master updates. That may be making people nervous about doing that. But it's really important that you remain competitive. If it's been over a year, make sure a thorough analysis is done that also compares your fees with other local facilities so you remain competitive. Maybe your charges need to go up in some areas. Maybe your charges need to go down in some areas. It's crucial that you ensure your charges remain competitive for your specific market. ICD-10 is coming. We should just assume that it is. Make sure all departments are kept in the loop in regards to ICD-10 testing and that you are clear what payers utilize diagnosis codes directly for reimbursement. Pay attention to any new contracts you're getting now. I'm beginning to see comments or paragraphs and ICD-10 specific provisions. Make sure you read those and you understand exactly how that's going to impact your reimbursement. Another thing that has been an area that can be avoided by many facilities is setting up all of your electronic processes. Maybe some of your payers go electronic, but not all of them. Maybe some of them you get electronic remits automatically posted into your billing system, but not all of them. Take the time, get everything electronic. It is more accurate and it saves a lot of time. It's well worth the expense, I promise you. Your contract management or billing software vendors should be able to offer you guidance on all of the issues I've outlined today. You are not alone. I think the first thing I would do is identify your revenue benchmarks, talk to your CFO, your BODs, find out what your revenue is, what your collections are, what do you want them to be? What is a realistic goal? Communicate those goals to your collection teams. Track your progress. Know when you've met goals and communicate that to the entire business office, since it takes cooperation from all areas to make sure your facility stays on track. Questions?
Thanks, Kristen. You finished early, which means we have time for some questions from the audience. If anybody has a question, they can just type it into the questions tab on your GoToMeeting dashboard, and I can send them over to Kristen.
Thank you. I covered a lot of ground.
You did. Well, here's one.
Okay.
What would you say is the best low-hanging fruit opportunity? If someone wanted to get started right now, would they go after underpayments? Would it be denials? Where would you say to start right away?
Well, it depends on the facility. You need information. You need to, like I said, identify what your biggest payers are. If you have a collections team, have them tell you what they're seeing. But run the reports to verify what they're seeing. It's very easy for collectors to get into a niche and then ignore things. If you've got payers who only, or collectors who only work certain payers, they may not be paying attention to other things. And make sure all of your payers are being looked at. If you're ignoring your Medicare HMOs, don't. If you're ignoring your TRICARE or your Medicaids, don't ignore those. If you have a high volume of workers' comp, that's important to take a look at if you have a high volume. Don't assume that those are being paid correctly. Every facility is different, so you want to run some reports and take a look at your accounts receivable. What are your biggest payers? And then start drilling down. What are your biggest reasons for denials? What are the biggest variances? Like I said, if your Blue Cross is your biggest payer and they have a lot of denials for inpatient, then you want somebody to start paying attention to that. Where's the biggest bang for your buck? If you do not have people working denials, get people to start doing that. If you do not have people working underpayments, start looking at those. A lot of underpayments are line item denials, but not all the time. So you need to have somebody taking a look at everything. Does that answer your question? Does that make sense?
Yeah. Yeah, that makes sense. Thanks.
Okay.
When we're talking about denials versus underpayments, how do you recommend allocating staff? Should that be the same group of people that tackles both of those, or how do you recommend?
Well, it depends on the volume, first of all, and it depends on your staff. You know what your staff strengths are. Usually, I recommend you starting with a 50-50 split. Have half your team working underpayments, which means it's a paid claim, but they've paid less than the calculated expected reimbursement. And then the other half of your team working denials. You could split your denial team any way you want. It can be by payer. That's usually the best way. Have one team person focused on your biggest payer. Have one team member who does the Medicare HMOs, another person that does Medicaid and Medicaid HMOs, and so on. As long as they have enough work to keep them busy. Make sure that they are well trained. Make sure that they communicate well between each other. If you have a team who's working underpayments, you want to decide if they have a line item denial, are they going to work them themselves, or are they going to pass that over to the denial team? That's up to you. The more people who touch it, however, the longer it takes for things to get fixed. I'm a firm believer in cross-training. So I think it really works best if you've got an underpayment collector and they've got a whole bunch of claims that are denied for missing authorization. It's not that hard to get that fixed and have the claim reprocessed. You want your clinical staff, if you have any available to help you with your medical necessity denials. They're kind of their own little unique animal. They can be a little, take more time. They take more work. Sometimes you have to type up your argument with the payer as far as why you believe that that was medically necessary. Don't be afraid to go after medical necessity denials. There's money there, and I think a lot of insurance companies take advantage of that and underpay or deny claims unfairly because of it. So I would start off 50-50, but make sure there is somebody looking at everything. Does that make sense?
Yeah, that makes sense. That's good advice. Thanks. And we had another one come in, and we'll see if you know the answer to this one, Kristen. Are payers allowed to take sequestration reductions of 2% automatically?
Well, your Medicare HM, yeah, absolutely. Okay. You have to. Yeah. I mean, I was really hoping that it was going to be repealed this year with all of the different reimbursement changes that the government's making, but so far it has not.
So that's across the board?
Well, we don't need to get into the specifics of how sequestration is calculated. No, it's not necessarily completely across the board. It's not a flat 2%.
Okay, and we had another one related to ChargeMaster, and you might have touched on this, but how often would you recommend a facility goes through a ChargeMaster review?
Well, if it hasn't been done in a long time, immediately do one. Do it yourself or have an outside vendor or a consultant do a complete ChargeMaster review of all of your services. They should be able to do a market study and compare to comparable facilities in your market. Once that's done, you'll be able to get a sense, you'll have a benchmark, and you'll be able to get a sense as to how rapid the market is changing or how big of a change. You may not want to, if you find huge gaps, you may not want to make one big change all at once. So if there's a big hop, you may want to, you may decide that it's prudent to make some changes beginning of the year and then revisit it again in the fall, for example. So it kind of depends on what the initial findings are. Usually every year is what we recommend, once a year minimum.
Okay, good. And with that, we'll do a last call for questions. We'll see if any more come across here. Well, I don't see any more, so with that, I think we're going to go ahead and sign off. Kristen, thanks again so much for your time. I think you put a lot of good information out here, and I hope that everyone in the audience is able to take away at least something from today's session. For follow-up, we will be sending out a copy of the slides along with the recording within the next day or so, so please be on the lookout for that. And we will be hosting we will be continuing to host webinar series monthly, so please be on the lookout. We're going to be doing specifically a charge master session in May, and then one focused on patient estimates in June. So we look forward to those. So thanks again, Kristen, and hope everyone has a great rest of the day and great rest of the week. Thank you.
Thanks, Brad.